My name is Dimitrios Lyrakos. I'm a clinical and forensic psychologist. And for the first presentation, we are going to discuss the topic about non-suicidal self-harm as a form of addiction. I'm presenting here four main definitions about self-harm. Actually, the term not suicidal self-harm is something that we have developed for the purpose of the study that we are conducting. It started by parasuicide, self-injury, self-mutilation, non-suicidal self-injury. As you can see, they're quite long. I won't bore you by reading it to them, but they all have one thing in common. They are talking about tissue damage and tissue destruction, tissue alteration, and they do not take into account other non-suicidal self-harm acts. That's the first thing. And none of the definitions include anything about frequency and repetition. Menninger, who is his work we'll see later on this presentation, was the first who talked about self-injury. He used the term self-mutilation in the beginning, and then he changed it to self-injury. Based on the theory, we have three major types of self-injury. We have the major self-injury, which involves permanent disfiguration, the stereotypic self-injury, such as head banging and biting, and we have the superficial self-injury, which includes cutting, hair pulling, and burning. Although we know nowadays that the main reasons for self-injury are psychological ones, nevertheless, so far we have not yet determined via any type of research why a person would take a blade to cut himself or herself, or to do any act that can be considered self-injurious. And so we don't have any ways to predict or prevent that kind of acts. There are two forms of non-suicidal self-harm. It's the cultural culture that includes also religious acts that can be considered self-harmful. And we have also the deviant non-suicidal self-harm, which includes acts that the person does in order to differentiate him or herself by the social norms and rules. Here I'm presenting to you the names that they have been used ever since we first started to trying to determine what this thing is. Partial suicide, self-mutilation, self-injury, self-cutting, non-suicidal self-injury. I believe that the last name is the correct one, non-suicidal self-harm, because it includes all the types of self-injury. In the study that we are conducting, we have determined so far 18 different types of self-harm. Only 3 of them are acts that destroy body tissue. As we have said, we have various. The first identification of self-harm was identified as religious acts throughout the world. Karl Menninger was the first to differentiate the self-injury behavior from suicide behavior, and has classified 6 main categories. The neurotic one, which is extreme hair removal, nail biting, biggest and unnecessary cosmetic surgery. The religious self-harm, which includes starvation, flagellation and purging. Puberty rights, which includes circumcision based to his theory. The psychotic ones, which is the most serious one, that includes removal of body parts such as eye, ear, extreme amputation. And we have the organic brain diseases, which is finger fracturing, eye or ear removal, head bagging. And finally, the conventional, which is shaving beards, trimming hair, and nail clipping. Towards the end of his career, he dismissed this particular category because we cannot consider someone who goes for a haircut that he does a non-suicidal self-act, but I'm including it here for historical purposes. Over the years, we have identified 7 different models, functional models of self-injury. We have the environmental model, which is based on family abuse and conditional learning. We have the anti-suicide model, that's a maladaptive coping strategy to avoid suicide tendencies that a person might have. We have the sexual model, which is quite simple. It refers to the pleasure that one hopes to get through that particular act. We have the affect regulation model, which refers to the self-injury that expresses intolerable and or overwhelming emotions. We have the dissociation model, which refers to self-injury that is used as a means of regulating an effective and a period of trauma. And finally, we have the interpersonal boundaries, which refers to self-injury. That's an attempt at simultaneously connecting and separating internal and external experiences. Although there have been a lot of empirical evidence and case studies that associate non-suicidal self-harm to addiction, nevertheless, it hasn't been a study with a large population to determine whether or not non-suicidal self-harm can be considered an addictive behavior. Over the years, and even with DSM-4, the revised edition, now in 5, it has been considered as a behavior. It was just considered another symptom in a series of disorders such as borderline personality disorder. In the study that we have conducted, which is quite large, 550 patients with non-suicidal self-harm, 214 of them did not fulfill any criteria for diagnosis other than the self-harm act. Here are the 7 basic criteria for addiction based on DSM. We will start by with each one of them, and we will see whether they are non-suicidal self-harm can be analyzed based on those criteria. The first one here, it's here, tolerance, which refers whether or not does the patient tend to need more of the drug. That's the definition that DSM uses over time to get the same effect. Actually, everyone who has therapeutically dealt with people who are or were engaged in non-suicidal self-harm would find out that there are indeed periods of time, especially stressful for the patient periods, that develop a tolerance, and they have a need in order to increase or make more severe self-harm behaviors in order to get exactly the same effect. Withdrawal. It's what in cognitive behavioral therapy we call the behavioral hole. When an addict cuts the addiction, we need to find a way or ways in order to get the same positive effects that he considered that he was getting from the addiction through other healthier ways. The same thing occurs with non-suicidal self-harm. Every patient who engaged in that particular behavior experienced the same whole, and it is one of the main things that therapeutically we had to deal in order not to repeat that behavior in the future. Now, continue to use the drug despite harm. I haven't encountered a single person who was engaging in self-harm that did not consider that it was harmful. No one ever thought that, okay, I'm fine, I don't have any danger. Actually, sometimes it's part of the excitement, the thing that I'm doing something. Usually, I'm the only one, maybe another person that knows about it, and it is something dangerous. It is something that keeps me on the edge. But they tend to disregard that danger basically because they get something by the act that they consider extremely important, exactly like in every other addiction. Loss of control. The strongest example that we can find about loss of control are the accidental suicides that a person that engages in self-harmful behaviors can occur. None of the people who are engaging in self-harmful behaviors want to commit suicide, but sometimes they are a bit more stressed, they are a bit more anxious, they cut a little bit deeper, or they engage a little bit more in the harmful behavior of their choice, and they are ending up losing their life. This is one of the strongest and most common loss of control symptom that we can find in people that engage in self-harmful behaviors. Attempts to cut down. Even though a person can have a disorder, depression, borderline, antisocial personality disorder, a large percent of the patients that go for therapy, they are going because they have a non-suicidal self-harmful behavior. They are not certain why they are coming, and they are not certain whether or not they want to cut down. We will see that later on another criterion, but they come, and it's one of the first things that they would admit. Not necessarily because they want this thing to be part of the treatment, but they just, for an inexplicable reason, they want to share that with the therapist. Does the patient spend significant time obtaining or thinking about the drug? Most of the people who are engaged in non-suicidal self-harm, they form their daily plan based on when they will engage themselves on that particular act. One very important, very interesting thing is that many patients say that this is a behavior that characterizes me. It's the main trait of my personality, and most of the times they're not certain, or they are unwilling to get treatment on that particular behavior because they're afraid that if I cut down and if I stop that particular act, then who will I be? Finally, reduced involvement. Patients that are having a non-suicidal self-harm, they avoid going on vacation, they change their working hours, they avoid going out with friends because they are afraid that if something happens and the urge to engage the act will occur, they won't be in the comfort of their own houses. So after a while, they stay home and their social functioning is severely reduced, exactly like in addictions like alcohol or drug. So, as we have seen, all the criteria can be met in a person that engages in non-suicidal self-harm. If you like, I can take, we can